Oh, it's 7 o'clock. Uh, Welcome everyone to Healthcare for All Washington's second Wednesday speaker series. We will be admitting people for the next few minutes, so that will continue. But my name is Ronnie Shure. I volunteer as president of the board of directors of Healthcare for All. Tonight, we will be discussing the final report on healthcare affordability by the Office of the Insurance Commissioner, and it will be presented by their senior health policy analyst, Nico Janssen, who has joined us tonight. He'll talk about the five policy approaches in this report and has promised that there's some tools in there that can help us, in leading our state towards the pathway to developing a true universal healthcare system. So this is a call to action tonight. We were going to use those tools to help build relationships among our fellow advocates and to work with legislators. We can do that right now by getting the right healthcare champions in the legislation. So vote. Uh, we also can pay attention to these initiatives that are reversing some of the work we've done in the recent past. So we certainly recommend voting no on those initiatives. You too can volunteer to be a part of the process for our organization. So consider joining one of our committees, our policy committee or communications committee or fundraising or outreach. In addition, you don't have to join a committee. There are specific projects that we'd love to have you work on. So we have entered our website into the chat in the Zoom link in this Zoom program, and we will continue to enter that as more and more people join us. And you can go to our website. You can find the donate button. We are certainly would love it if you are able to donate to our organization to help with our lobbying and with our communication programs. You can also go to the button and navigate to the button that says get involved, and that's where you can volunteer. And while you're on the website, you can, help us by following some of the actions we're taking. We have set a goal of raising $250 during this program tonight. And in the chat, you can go there anytime and you won't get logged out of the meeting, out of the Zoom meeting. And you can make a donation or you can hit that get involved button and enter information and let us know where you want to get involved. The PowerPoint tonight will be available on that website. It's not there yet, but Nico has told us he will share that with us, so it should be in there. There certainly are advocacy goals, and we are gathering a list of healthcare champions that have answered our candidate survey, so you can identify people that have the same interests. And you can see a lot of our actions in that website. So there's lots of reasons to go there. Tonight, we will use the chat to track any questions you have. So please, at any time, go into the Q&A or into the chat and add a question. After Nico's presentation, we'll stop, gather some of those questions together, and then Cello Echeverria, one of our members, our board members, will join with Nico in answering those questions. So please go into the chat at any time. Also be aware we've activated the closed caption icon. So go to the bottom, hover over the bottom of your Zoom screen, and you can enable that CC or closed caption button to see captions, closed captions. I'm participating tonight in this Zoom meeting from the lands of the Coast Salish peoples. Our effort to achieve healthcare for all people includes all peoples of this land. And so please take a minute to acknowledge the peoples in the lands where you're joining from tonight. We acknowledge all of the ancestral homelands and traditional territories of indigenous peoples who have been here since time immemorial. Our efforts to achieve healthcare for all includes universal healthcare coverage for the Coast Salish peoples of this land, the land which touches the shared waters of all tribes and bands within the Duwamish, Muckleshoot, Puyallup, Suquamish, and Tulalip nations. So let's highlight Nico and ask you to unmute. Uh, Nico is the Senior Health Policy Analyst with the Office of the Insurance Commissioner. He grew up in Port Townsend, where he graduated from high school, and he attended Seattle Central College. After getting his AA degree, he attended American University School of Public Affairs, where he received a BA in political science and policy, and then an MPA in health policy. He remained in Washington, D.C. for 13 years, where he was a staffer in the U.S. Senate for 3 different senators. And he worked in the U.S. Department of Health and Human Services on federal healthcare policy issues, such as Medicare coverage. And he was there during the Affordable Care Act was developed. So he brings a multifaceted approach to his job here, welcoming him back to Washington. Outside of work, he's a songwriter and a musician, and he lives here in Seattle. So let me welcome you, Nico, ask you to unmute, and let's give you the screen and remove me from the screen.
Okay, thank you so much, Ronnie. Can you hear me?
Yes.
All right. What a thorough introduction. You had parts in there that I didn't even I didn't even have in there. Yeah, small town from a small town, and well, growing up, a lot of my family members were involved in healthcare in some fashion. A lot of providers, and really the reason that I became interested in the public policy of healthcare was learning about it a little bit and being really concerned about the cost, some of the perennial issues in American healthcare. Why does it cost so much? Why is access poor? Why is it, not better quality? And it's been an interesting start of my career for the last 10 years working on those issues. So let me share my slides. Okay. And then I need to go and select the right setting here. Okay. Tell me if you're seeing it in a way that looks correct.
Looks correct to me.
Okay, good. Okay, so I work at the Office of the Insurance Commissioner, or the OIC. I'll just say OIC for tonight. Many of you know us, have probably had some interaction with us in your work. So I'm pinch hitting tonight for Jane Beyer, who was originally going to present for us. She had a conflict. So we're within the policy division, and we support the OIC's work with the legislature and our rulemakings, where OIC implements the bills passed by the legislature. So tonight I'm going to talk about the final affordability report that the OIC released in August. And I'm going to start with why we did it. The legislature wanted to look at the specific effects in Washington state of implementing policies to try to improve healthcare affordability. Not just the national picture, not just estimates at a national level or studies that might not be applicable to Washington state because Washington is unique, but what would the effects be on premiums, on the state budget, and on the economy of implementing specific policies. So that's what we set out to do. We did 2 reports as part of this effort. There was a preliminary report that we released last year, and then there was the final report that we released in August of this year. And I should note that the Attorney General's office released a parallel report on this topic as well, which focused on anti-competitive practices in healthcare in Washington, which is a very good report as well. So responding to that longstanding concern, and ever since I've been working in the public sector on healthcare issues, seeing the premiums go up in the individual market across all the forms of insurance that people have, and the ways people are getting healthcare, seeing the costs rise. This was meant to give a Washington specific look at some of those policies. Okay, so here's I think a good kind of context setting visual for this report, because for each policy, we identified the parts of the healthcare coverage system in Washington that the various policy options would affect. And so you can see here about half of the whole pie is Medicare and Medicaid. And the other half largely is the commercial market. And as part of the commercial market, you have a portion of the commercial market that the OIC regulates, which is known as the fully insured plans, where the health insurance plans are responsible at financial risk for the claims. And then you have what are called self-funded plans. Big employers, Boeing, Microsoft, Amazon, are self-funded plans. They're commercial health plans. They take on the financial risk, and they hire third-party administrators who are oftentimes the same types of insurance companies to run those benefits. So half Medicare, Medicaid, half commercial, and the policy options we looked at in this report affect from a small portion of this entire pie to almost all of the pie. So the preliminary report I'll talk about briefly. I want to get into some of the policy options and the results, or the findings, I should say, from the final report. But the preliminary report really was about understanding the structure of Washington's current healthcare system, and then discussing a range of policy options to determine which ones to study in more depth. Some of the biggest themes from our preliminary report is that vertical integration and horizontal consolidation have really been increasing in Washington's healthcare system. Vertical integration would be when two different parts of the healthcare sector merge, like if United Health Group as an insurer owns Optum, which is a healthcare provider. That's an example of vertical integration. And then horizontal consolidation would be, when Providence took over Swedish. That would be an example of horizontal consolidation among health systems and hospitals, is a good example of that. So, some of the takeaways from this report of note were that we found that about 40% of all the hospitals in the state are part of just 5 of the largest hospital systems, and about 80% of all the licensed beds are part of multi-hospital systems. We also found that about half of all physicians are now employed by hospitals, and 65% of them are employed by health systems that have more than one hospital. We also looked at the vertical integration among insurers, like I was referring to on the last slide. We found a lot of integration between pharmacy benefit managers and pharmacies, physician groups, healthcare benefit managers, third-party administrators. So, I think some examples of this are the fact that, you have some pharmacy benefit managers that own pharmacies, and then they also own or are affiliated with large insurance companies. So that's an example of vertical integration, which we've seen a real increase in. And just in the last couple of years, we've seen some really big examples of that. We also looked at the entry of private equity firms and private equity investments in Washington's healthcare system, and found that that there's a significant number of acquisitions. We found in a 10-year period almost 100. We looked at some of the key investment areas of private equity in healthcare, some specialties like dermatology, ophthalmology, have some of those investments, but as you can see here, it's really pretty broad, the categories and types of healthcare facilities. And then we noted that some emergency physician groups and anesthesiology practices are also being invested in by private equity. So with that preliminary report, we took a menu or a list of different policies and determined that we would study five of them. And the reason that we ended up studying these five is because they affect different sectors of the system. For example, some are trying to get at affordability by changing something that the insurance companies are doing, or the health systems or the hospitals, but they're not all aiming at one direction, so to speak. And then we looked at the feasibility of doing what's called actuarial analysis, where you will analyze a change in policy to the premiums that people would pay, the actuarial values, that kind of thing. And you can determine the cost that way. So the five policies that the OIC in its report looked at were: first, establishing a reinsurance program; second, increasing what's called the medical loss ratio standard, or the MLR standard; three, creating a reference-based pricing program; fourth, hospital global budgeting; and fifth, we did an economic analysis of basically what the effect would be of the state meeting the growth benchmarks, excuse me, that the Healthcare Cost Transparency Board has set. So those are the five policy options that OIC looked at in this report. Okay, before I start talking about reinsurance, Ronnie, can you tell me how much time I have? My screen just has the slides. I want to make sure that I can.
It's 7:19. You have like 15 minutes or so, or 20
Okay.
minutes?
Okay, great. Okay. So the first option is creating a reinsurance program. So getting back to the pie of these different sources of healthcare coverage, the reinsurance program would have a relatively small share of the of all of these coverage sources affected, namely the individual insurance market, which includes Washington Health Benefit Exchange, and the small group market, so excuse me, small employers who offer coverage. So reinsurance programs work by setting aside funds to pay for a portion of really high cost claims, therefore reducing some of the risk for insurers and lowering the premiums across the whole insurance pool. So a lot of states have reinsurance programs. Some of you may have been involved more than I in 2018 when the state was considering establishing a reinsurance program, which didn't end up happening. And reinsurance can be most helpful to people that are paying the full cost of insurance in the individual insurance market, because people who are already getting federal subsidies, there's not as much of an effect on their premiums being lowered. So what we did in this report is we looked at what would the effect be of trying to get a 10% premium reduction through establishing a reinsurance program. I'm going to skip through some of these busier slides because I don't want to get lost in some of these tables, and I don't have a lot of time to get through everything. It's a 150-page report, so we've really been trying to communicate it effectively and kind of get to the bottom line. But I think this slide is probably most instructive for understanding reinsurance. The key takeaway is that with reinsurance, you're lowering premiums in a subset of the whole insurance market. But the disadvantage for policymakers, for the legislature, is that there's a significant state funding that would be required. What would happen is the state would come up with part of the money, and then the federal government would come up with part of the money through a waiver program. And then that would be arranged based on how generous the reinsurance program is and how it works. And so here you see the range where we estimated that in the individual market, it'd be between about 42 and 84 million, and in the small group market between about 150 and about 300 million in state costs. And then the federal government, through a quite arcane, complex method, gives money they would have paid for subsidies back to the state in what are called pass-through dollars. So the advantages of it is it's been tried. Other states have done it. It does lower premiums to a certain extent for some consumers. But I think some of the disadvantages that we highlighted in the report and discussed are you have significant state funding that's needed. It has a limited impact on the lowest income consumers because it's affecting more the people that are paying the full price that are middle or upper, middle to upper income, maybe more middle income, I would say. And then I would just say also, it is moving the mechanisms by which the money flows. It's not attacking the price that's paid for healthcare services. So you can have some lowering of premiums, but you're not getting at the root cause of healthcare costs, meaning the prices that are paid for healthcare services and the volume of services. Okay, so that's reinsurance. So the second policy option is to increase insurance companies' medical loss ratio standards. There's an acronym people use with this that just say the MLR. This policy would affect a little bit of a broader share than the reinsurance approach. So this would affect the part of the commercial health insurance market that the OIC regulates, which is these fully insured plans. So the Affordable Care Act sets a federal standard for this, and basically the medical loss ratio is the percentage of premiums that insurers collect that they pay out in healthcare claims. And current federal law says if you're an insurance company in the individual or small group market, you need to pay out 80% on healthcare claims or quality improvement efforts. And for a large group, it's 85%. And if the insurance companies don't meet the medical loss ratio standard, it's calculated on an aggregate level in the average, so it's not at the individual consumer level. Then they need to give a rebate to consumers for the difference. I think the key takeaway with this policy is that what we found in analyzing the current medical loss ratios of carriers in Washington is that most of them already are close to or at the 88% that we studied in this report. So to clarify that, the current rates are 80 and 85%, which is what federal law says. In this report, we study the impacts of raising that to 88%. So again, just to try to get the most salient points across, I would say here the advantages are you don't have state funding that's necessary, and you have a relatively lower cost to administer a program like this. But the disadvantage is because of our analysis of what's currently happening in the market, the impact on premiums is really small. In fact, I think the range is around less than to maybe up to only about 3%. So a 3% decrease in current premiums for consumers that would be affected. And I'd also note that if one insurance company is above the minimum medical loss ratio, then their consumers wouldn't benefit, right? Because they're already above that. This would only affect the carriers or the insurance companies that aren't meeting that medical loss ratio already. In our report, we have a chart of where all the insurance companies are on this measure, the medical loss ratio. And there are one or two that are outliers that are paying below that 80 and 85% right now. But the majority are near or above the current requirements. So that's the medical loss ratio policy.
And Nico, we're doing really well. It's 7:25, so we're moving along smoothly. But can I remind people that the chat is open for questions? So as you find questions along with, during Nico's comments, please go into the chat and enter those questions. Thank you.
Okay. I see some really good questions and comments in the chat. Um, I'm going to go through the last three policy options that we looked at in this report first, and then we can look at the comments. The third policy option is called reference-based pricing. This policy option could potentially affect the entire commercial market in Washington, depending on the way that the legislature would want to design it. It could apply to the fully insured part. It could apply to apply to the whole commercial market, including those self-funded plans. So the concept of reference-based pricing is you're establishing a standard reimbursement rate for certain healthcare services, and it's tied to an already defined level. And usually when we talk about reference-based pricing, the reference is Medicare. So why Medicare? Medicare has fee schedules that are updated every year. CMS, the Centers for Medicare and Medicaid Services, adjust that every year. And according to the Medicare Payment Advisory Committee, who advises Congress on Medicare issues, Medicare reimbursement is designed to give a break-even payment for efficient hospitals. That is part of the reason why a lot of the reference-based pricing proposals are tied to Medicare. So Oregon uses reference-based pricing for their equivalent of the PEB and SEB programs, their state employee, school employee programs. They've seen savings. Montana has also seen some savings, although their program, I think, has changed or scaled back recently. And Washington already has a form of reference-based pricing with the Cascade Care Select plans, which are reimbursing at 160% of Medicare, and the exchange has seen lower rate of premium increases than the non-Cascade Select plans. I do want to emphasize this chart. This is from the commercial insurance payments we looked at as part of this report. It's from the all-payer claims database. And this is the commercial health insurers, mostly in the fully insured part of the commercial market, reporting this data. We basically analyzed it in a way to say what percentage of Medicare is it currently, right? In order to predict what the effects would be of instituting a reference-based price, you have to know what percentage of Medicare is currently being paid. And this is not different than I think a lot of evidence that's already out there that says different services are paid with wide variation. So we see mental health and substance use disorder professional fees, which could be therapy, psychiatry, or health provider fees that aren't the facility fee, aren't the hospital fee, at just 88% of Medicare, whereas we see hospital emergency room visit reimbursement at 309% of Medicare. So these are averages, and we, in our report, have several tables that go through by service what is currently being reimbursed. What we did for our modeling in this report is we modeled what would happen if you did 160% of Medicare for a reference-based price across providers. So that's consistent with how the Cascade Care plans are currently reimbursing. So that's what we studied. We assumed that it would be at 160%. So the impacts from reference-based pricing, there's a wide range of a potential reduction that you could get in healthcare spending from it. Up to 19% reduction in healthcare spending is what we found. The reason it's such a wide range is because there are some issues in the data we used to do this actuarial analysis, there is some level of information that's not reflected in the actual claims that are being paid. That is also part of the healthcare spend, like capitation payments or risk sharing payments, and some level of missing claims within the database we used. So we did a couple of different scenarios to try and get a good sense of, okay, this data set might be lower, but other data that other organizations have looked at is higher. So anyway, we presented it in a few different ways to account for that, and that's why there's a large range. But the direction is the same, which says that you will save money overall by requiring carriers to pay a different rate than they are. That would, at 160% of Medicare would be significantly lower. Or if the legislature chose to structure it by capping what the providers can charge, that would be another way they could address it. So let's see. Summarizing reference-based pricing, the key takeaway is it is going to the underlying price that is being paid for healthcare services, which is a big difference between the last two proposals I talked about. You are capping rates, and that doesn't take direct spending by the state because that's how you're getting the savings. It could incentivize services that the state might want to provide more of. For example, it could set floors for services like primary care, behavioral health, or whatever service that policymakers wanted to kind of prioritize or make sure there's access to primary care, in addition to setting the ceilings, and could increase the transparency. But some of the disadvantages here would be very complex to implement and administer, and could cause disruption in the healthcare delivery system. There are different types of providers, different types of facilities, and so it gets quite complex because not everyone is paid the same. There's a wide variation, like I was saying earlier.
So your
Okay,
timing is really good, Nico. I just want to remind people that put your questions into the chat at the end of Nico's presentation, where we will get to those questions. So thanks for being so impeccable and right on time. I'm not trying to push you along. I just wanted to push people to ask questions.
wonderful. It's always hard to cover such a large amount of information that's complex in a short amount of time, even though 30 minutes is a lot more generous than some of the time slots. So the last policy is hospital global budgeting. Looking at the same pie chart that we started with, out of all the policies, this has the potential to affect nearly the entire picture of health coverage in Washington because it could potentially encompass Medicare and Medicaid. So the concept with hospital global budgets is that you establish a rate for hospitals that are the same for all payers, meaning Medicare pays the same rate that commercial plans pay, or Medicaid plans pay, right? And then hospital-specific revenue targets are, cost growth benchmarks are set as well. So like year-over-year costs are set. So basically, you're establishing a global budget, which is applying to multiple payers. So there's certainly a lot of evidence to suggest that paying on the current fee-for-service model that a lot of payers have used and traditionally healthcare is paid for, there's been concern that that incentivizes increased volume of services. And so part of the concept with hospital global budgeting is to get away from that and incentivize hospitals to not just try to provide more services and increase volume, but increase efficiency. There's really only one state or example in the United States of a large-scale hospital global budgeting model, and that's in Maryland. And they've been doing it for several decades, and it's followed some different iterations. this is before my time, but Washington, I understand, established a hospital rate setting statute like Maryland's, which was later repealed. So what we studied for our report is the impact of limiting hospital cost growth, the growth in hospital costs, to 2.8% per year per person. And the reason we chose that 2.8% number is because that's the number that the Washington Healthcare Cost Transparency Board has come up with as a cost growth benchmark, right? That they've contemplated. We evaluated a scenario that assumes that all acute care hospitals must participate. It's mandatory, not voluntary. However, we excluded from our analysis critical access hospitals, psychiatric hospitals, rehabilitation hospitals, and children's hospitals. And then kind of a note on hospital global budgets. Excuse me, something that Maryland has done with theirs is taken some of the savings that they've achieved from setting this global budget at a basically that achieves a savings versus what they otherwise would have paid. And using some of that money to put into primary care initiatives, that kind of thing, quality of care initiatives. So that's a component we discussed in the report. So the overall impacts of this, we have, again, a fairly wide range, but up to about a 7% reduction, excuse me, in hospital costs. A lot of variation depends on how the program would be implemented, and potentially higher enrollment, due to greater affordability. So this policy, like reference-based pricing, attempts to deal with the price paid for services and therefore promote more affordability by having that then affect what consumers are paying for premiums and their cost sharing that goes into that, the underlying prices paid for services. So let's see, I just want to make sure I wrap up on this one. Some of the disadvantages we discuss with hospital global budgeting is a lot of complexity, and could represent a very big change to current hospital financing. And there's a lot of variation in the types of providers and hospitals out there. Also, it would require working with the federal government to negotiate a very substantial waiver that would allow the Medicare and Medicaid part to be a part of it. Okay, I'll be really quick here, Ronnie. I'm almost done. The last one is we just did an economic analysis of basically the savings that could be achieved if broadly the state were able to meet those benchmarks I mentioned before that the Healthcare Cost Transparency Board has set. Again, this policy, because it's kind of global across all of Washington's healthcare system, could potentially affect nearly all Washingtonians. So currently, the board measures and reports on the annual healthcare cost growth. The potential policy option we discussed and looked at is adding enforcement authority to those benchmarks. Currently, there is not enforcement for that. There's really nothing to stop the costs from exceeding those benchmarks. So we discussed enforcement authority, like imposing performance improvement plans if health systems or sectors of the healthcare system don't achieve the cost growth benchmarks, fines or penalties. And we note that some other states have some enforcement authority into their laws. So they go further than Washington currently does. Excuse me. So these, because it's in millions, you can look at in terms of extrapolating that out to basically like 1.4 billion on the top row, or the 5-year period there, 2025 to 2029, 8.4 billion. So we gave some kind of macro estimates of the projected savings of achieving these various spending growth targets year by year. Excuse me. And again, this follows the Healthcare Cost Transparency Board's cost growth benchmarks that they've put out. So I think the key kind of disadvantage or issue we discussed here with this policy option is that it's unlikely these cost growth benchmarks that the board has set are going to be effective, meaning it's unlikely they're going to be met unless they have some effective enforcement. But we also discussed that this could be a method where it wouldn't mandate specifically that one health system or one specialty or one part of the system necessarily achieve X reduction. It's more global. So, that could have some benefits by being more flexible. To sum it up, to wrap it up here, we concluded that the 5 policy options we studied could meaningfully help with affordability challenges for consumers, for employers, and for the state and for the economy. There are a lot of advantages and disadvantages to each option. What we aim for is for this report to be useful to the legislature, useful to you, useful to all the groups we interact with in giving Washington specific information and continuing the conversation. And then the last thing that I'll mention, Ronnie, before we go to any questions, is that we're presenting this report for the Universal Healthcare Commission, and also for the House Healthcare and Wellness Committee has an interim meeting in December. And then I just want to say that I really appreciate all of the advocacy work, the volunteering that your members have been doing. It's having been a congressional staffer, I know that it's really a struggle to see large scale change happen, and I really look forward to engaging with you. And I'm new to the OIC, and so I'll be meeting you and being able to interact with you more. And I really appreciate your work, and I really look forward to working with you on these issues and your work towards a universal healthcare system. Thank you.
Well, thank you. And if you could turn off your slides. Thanks, Nico. Thanks for sharing that information. So we've got some specific numbers that we could use. It seems like too detailed information in some cases, but that's what we need to do to advocate for a healthcare system that improves the quality of care. So while Nico and Cello are gathering those questions and lining them up, would just like to ask you all to support the work that we're doing and taking numbers like this. And Nico, you did a great job of giving us the bottom line on each of these issues. And you'll notice that nobody dropped out and left us because the numbers were overwhelming, but they are only an indication of what work we really need to do to improve the healthcare for everyone. Administrative costs are such a big part of the healthcare expenditures, and it's time for us to really battle those and come up with a comprehensive plan. Certainly, we at Healthcare for All feel that a single payer plan of pulling out many of those administrative costs will make healthcare available to more and more people and will enable the system to create better outcomes. So thanks for sharing that information with us. Please take some time to enter questions into the chat, and note that we've added the donate button. If you can support us and our communication and lobbying efforts, it is mostly volunteers, but we do fund or pay for a couple of staff members to help keep us all going in the right direction and to make those connections. So why don't I bring Cello, if you're ready to start with some of the questions, and I'll bring you back on, Nico. Uh, and just be aware that in the background, we've got John Britt and several other volunteers that are helping to support this process. But Cello, you're going to lead the Q&A, and so you get to ask the first question.
So I'm going to ask my question first because I get to do that. This is a question, and Chris Curry hinted at it as well. I am curious as to why the larger administrating costs of billing and insurance related expenses, BRI, is never modeled in these cost estimates. BRI, which includes, this is for people who don't know, not you, Nico, includes claims management, clinical documentation, coding, and prior or authorization, which the literature finds as administrative waste because it adds nothing to the quality of care and is a driver of moral injury in providers. The waste is significant, as shown by both the actuary reports in the Oregon Task Force and the Washington Work Group, which show a savings about $1 billion a year alone in administrative savings if we consolidate administration. How can we support the OIC to include BRI in your models?
That's a really good question. And I think that we see a lot of just continual examples of how fragmented the system is. And one thing that OIC tries to do when working with the healthcare authority and the legislature is to standardize where possible how a policy is going to apply across the parts of the system that the state does have a role or control in shaping, so that we don't have differing or conflicting systems. I think prior authorization is an example of that, where you have a lot of different systems going on, and the goal is to have more of a standardization of the process that has to be followed for submitting requests, that kind of thing. As to the question of the modeling, I joined this agency and this job while this report was underway. So I can't say that I was part of the decision making on which policies got modeled, but I would say that the agency chose them to have to look at the effects of policies that would affect different sectors, different parts, and what types of policies could be done with doing an actuarial analysis. So I don't know specifically if there's a reason behind that question of why didn't you model some kind of policy on reducing the administrative cost. But I think that ultimately we had limited funds, limited time, resources, and we did these 5 policies because we thought they were, provided a variety of policy options, affected different parts of the system and different insurance markets. The last thing I'll say is that OIC does the rate review process for the individual insurance market and the small group market. So for people that get their coverage through the exchange here and through small employers, we will review those rates to see if they're justified, right? And so that is also a way to look at, is your healthcare cost experience and the claims experience justifying the premiums you're charging? And we commonly will get a proposed premium increase, and then we will actually approve a lower premium increase than what was proposed by the insurers. I think I answered a little bit of your question. I know I didn't get to all of it, but I want to acknowledge that it's a really good question, something I'm interested in learning more about.
Thank you. So the second question, which is kind of on the tail of this, from David I'm going to mess up his name. I always mess up your last name, Mac. I'm so sorry, from PNHP, is can you comment on private equity buying hospitals, clinics, selling assets, and then getting out of owning the hospitals and clinics?
Well, for OIC right now, we're going to have a new commissioner in January. What OIC's policy position, legislation might endorse, or kind of speaking more ideologically, is not necessarily something I could say. But I think that it's something that at the national level, a lot of policymakers have been looking at because there have certainly been instances in other states like Massachusetts where you've had private equity investments in healthcare really negatively impact care. And so we have colleagues across the other state agencies, and certainly there are a lot of groups in Washington who have been talking about potential policies to have more oversight or more enforcement regarding those types of transactions. I can't really speak to how the OIC as an agency feels about that. And I think that it certainly is something that we monitor and look at and are interested in.
Thank you. That's very useful. Thank you. And now I have a question from Richard Glue, also from Physicians for National Health Program, about global budgets. He asked, when hospital global budgets, with hospital global budgets, would hospitals still bill individual patients, or would they just get a pot of money based on previous costs?
I think the way it works in Maryland, and this is a very good question, is the individual payers, Medicare or a commercial plan, for instance, are still paying for the claim, but the budget is set to control that. So I'm trying to think of the best way to answer your question. The way that I understand it working in Maryland is the patient still has their individual source of coverage. And yes, they still could have a cost-sharing payment that's applicable for that. So if I'm a Medicare patient and I have my office visit, I might still have my coinsurance, or my Medigap plan might have, pay for that, or however it's done, right? So is that, I hope that that's helpful. It is not changing the benefit design per se of people's individual coverage. But the idea is that by setting a budget, you're saving money compared to what you otherwise would have been spending.
But it will still be payment at point of service, most likely.
I think that's the way that it is working in Maryland.
Okay.
Yes. So the general benefit design of, let's say I have a deductible or I have a copay of this amount, the patient would still do those things at the point of service. That's my understanding. It's a really good question. It's very complex. Maryland has a lot of experience with it, and we've definitely been interested in what Maryland's doing as part of this effort.
Now I'd like to move to reimbursements. Chris Curry's got some questions from Healthcare for All Washington. And Chris, if I'm paraphrasing you incorrectly, please feel free to hop in. The first question that I'd like to ask that he mentions is, doesn't it seem rather pointless to further subsidize insurance companies with reimbursements and spend even more state money in the name of lowering costs? Carriers are adept at raising premiums and expanding the definition of medical care to get around current ACA-MLR requirements. How might Washington deal with that problem?
Yeah, it's a really good question. In the report, we do mention that one of the potential effects is that insurers see the effect differently than the regulators might. And the result is that it doesn't have as positive an effect in terms of either they're raising their medical loss ratios or paying rebates. And yes, I think that we acknowledge those potential instances, or in any policy, the potential for gaming, if you will, to occur. I think other part of the question with regards to the idea of subsidizing services, I think that was part of the legislature's debate of a potential reinsurance program and pursuing a federal waiver in 2018. What I would say is that the OIC, in doing this report, in its discussion of the policies, distinguished between those that are trying to lower the underlying price paid for services versus getting a premium reduction by another mechanism. So I agree with the concept or the assertion that reinsurance does not address the underlying cost of healthcare. That's a true statement. It could lower premiums, but it does not affect the underlying price paid. And that's what we found, and that's what we said in the report.
Chris, do you have anything you want to add to that?
No, go ahead.
Okay. Because we're running out of time, I apologize. There's a whole slew of excellent questions, but I just want to end with this one because I think this is a really good wrap-up question. First of all, what actuarial firm did your analysis, please? If you know that, and if you don't know that, could you possibly email that to Marcia or Ronnie?
OIC contracted with Health Management Associates, HMA.
Okay.
HMA had Wakely do the actuarial analysis. So Wakely is the firm that conducted the actuarial analysis.
Okay.
And a separate consultant conducted the economic analysis.
Perfect. And then finally,
we have a healthcare affordability page on OIC's website, and we link to the report, a 2-page summary, and then we mention our process and who did those.
Okay. Thank you. And finally, Marcia asks from Healthcare for All Washington, does the OIC have a preference for which one of these policy options they would recommend? And if so, what is your process of getting it or them enacted?
Well, right now, we're going to have an election and we're going to have a new commissioner, and the direction and policy agenda of the agency is largely going to be shaped by who becomes the commissioner and what their agenda is. Our objective with the report is to give the legislature more information and more tools. I can tell you that the current commissioner supports these policies and the legislature considering them. But if your question is OIC going to push for one of these policies, it's possible, but I'm not going to speak for the agency because we're going to have new leadership really soon, and that's going to set the tone.
Fair enough.
Well, thank you. Thanks, Cello, for bringing in those questions, and thank you so much, Nico, for getting us through that data and providing us with those tools. Next month, instead of our second Wednesday speaker series, we will be having our annual meeting. It'll be Saturday, November 9th. Senator Patty Kuderer, who's a candidate to be our next insurance commissioner, will start out next month's discussion, continue some of the items we talked about today. So join us at our annual meeting on November 6th. I also want to remind you to vote. Vote early, mail in your ballot to ensure that we have healthcare champions in the legislature and in statewide offices. And of course, remember that there are those 3 initiatives that could reverse our previous victories. I want to thank our volunteers for all the work to facilitate events tonight. Thank you, Nico, for your presentation and for bringing your perspective, your federal perspective, as well as your work in the Office of the Insurance Commissioner. So thank you. I also want to thank people in the background tonight, Ron Lovell, Rich Legoo, and John Britt, who have been helping us negotiate and keep the sound and spotlights working. And thank you, Cello, for helping to lead this discussion, the Q&A. It's hard to pull out the most important questions. Our communication team who promoted this event and brought so many people here is what really makes this an organizational event. So thank you to Marcia Stedman, to Sydney Jones, to Ron Lovell, Connie Rock, John Britt, and to you, Cello, and D.W. Clark. And most of all, I want to thank each of you for being interested in this topic and in helping to improve the healthcare outcomes in our state. Washington is doing some real forward steps along this pathway, but we have a long ways to go. So thank you for joining us tonight, and see you in November. Thank you all.
I just want to say we didn't get to all of the questions in the chat. I'm copying them all. I will try my best to answer them to you either as a Facebook post or something. We will try our best.
And go
And I'm
to our
sorry I
website.
couldn't get to them all.
Go to our website to watch for those answers. We will have Nico's slides available, and we also will have a link to the PDF of that full report. Actually, there's a summary, which is much easier to look at those key messages that Nico shared with us, as well as the longer report. So go to our website. There's still time to make a donation tonight. Thank you for each of you who are able to do that. And we will see you next month. Thank you all.
Thank you.